Hello, NCS podcast listeners. Welcome to another episode of the Neurocritical Care Society podcast. This is your host, Fawaz Al-Mufti. The challenges posed by traumatic brain injury involve the management of the initial insult, in addition to downstream inflammation, edema, and ischemia that can result in secondary brain injury, which is often subclinical, but can be detected through surrogate physiologic changes such as ICP, cerebral blood flow, brain tissue oxygenation, cerebral metabolism, and electroencephalography. Comprehensive multimodality monitoring provides an opportunity to guide management in a more precise, patient-specific way. While many centers routinely use multimodality monitoring in TBI patients, many remain skeptical. What is the best approach? Where is the optimal location for placement of the probes? What are the risks, and how long before these monitors stop working? Dr. Brandon Foreman and colleagues from the University of Cincinnati sought to answer these questions. In this episode, Dr. Ballou discusses with Dr. Foreman his recent article entitled Safety and Reliability of Bedside Single Burr Hole Technique for Intracranial Multimodality Monitoring in Severe Traumatic Brain Injury. Hope you enjoyed this podcast.
Hello and welcome to the Neurocritical Care Society podcast. I'm Ramani Ballou. So I'm really happy today to have Dr. Brandon Foreman from the University of Cincinnati as our guest. Brandon, welcome to the Neurocritical Care Society podcast.
Thank you so much. I appreciate being on. Thanks for having me.
Sure. So thanks very much for taking time out of your busy day to sit down and discuss your recent paper in the Neurocritical Care Journal that describes the reliability, safety, and clinical feasibility of a standardized single burr hole technique for intracranial multimodality monitoring in TBI. But to start off, can you tell our listeners a little bit about your clinical and research interests and how these dovetail into the work that we're going to be discussing today?
Yeah, absolutely. So I'm a clinical neurophysiologist by training and did neuro-ICU as well after my residency in neurology. And so my interest really is in cortical physiology and how it changes and is dysfunctional after an injury of any kind. And so this particular work actually came about as a result of trying to standardize how we're measuring those physiologic changes in our particular patient population here in Cincinnati, which happens to have a lot of severe traumatic brain injury.
So, what I'm going to do, I'm going to approach our discussion today from the perspective of the neurointensivist who's thinking about implementing invasive multimodality monitoring in their hospital, but hasn't really done it yet. And let's assume that this person practices at a high-volume center that sees patients with severe brain injury, but that the only real invasive monitoring that's done at that center is with an EVD or a ventriculostomy drain. And the questions running through this neurointensivist's mind would probably include the following. Number one, is invasive multimodality monitoring safe? Number two, is it effective? Does it improve patient outcomes? And number three, and I think this is a really important one, what would be the practical steps needed to set up a pathway for multimodality monitoring?
Yeah, absolutely. So, we're certainly not the first or only center that's doing this. And so I took a lot of cues from my own training. I learned under Stefan Mayer and Jan Claassen over at Columbia, and taking a cue for what I saw there and how multimodality monitoring can be applied. When I started here in Cincinnati, I kind of recognized that this was something that would be of interest. And fortunately, Cincinnati has had a long experience too of working with multimodality monitoring through work from Jed Hartings and Lori Shutter, who was here before me. And so, it was kind of ripe for exploring how to sort of apply this in a different way. And so we had this opportunity to sit back and say, well, how can we standardize what we're doing? How can we take some new devices that we haven't used before and some new technology, including this quad lumen bolt, which we happen to use for this, to really streamline and simplify what we were doing. One of the neurosurgeons that was here when I started, Dr. Andaluz, had kind of spearheaded arranging to get the equipment through our hospital system. And we sat down and we said, from a practical standpoint, who would we do this on? And we kind of set forward a pathway to say, okay, if it's 2 a.m. and there's a patient who comes in with a traumatic brain injury, what are their criteria in which that patient then would get this monitoring, such that when the clinical team shows up from the neurocritical care side of things, that the patients got monitors, got data, we're ready to start making some decisions. And that was our first step, is just identifying what that clinical criteria would be. Here, because our traumatic brain injury patients tend to have other injuries that can confound things like the Glasgow Coma Scale score, we sort of did a nuanced pathway that said, well, if you've got command following but no eye opening, you don't necessarily need intracranial monitoring. Or if you have an alcohol level of 350, obviously you might have a washout period where you try to see if the exam's been confounded. And that was, in this particular article, included as supplementary data because I do think for most centers, everyone's got their individual criteria, but it was nice for me in developing this here locally to hear from other people who'd done this and what their criteria were.
Right, and this was the appendix to the paper that kind of describes what your center's algorithm is for deciding who is a candidate for invasive neuromonitoring. Is that right?
Right, exactly.
Yes.
And it's certainly not, I think, something that becomes a standard that should be applied everywhere. I think every center has their own nuance, and so it kind of serves as more of an example. And I think that's the key thing is, yes, you can do this, and it's helpful to see how other people have done it and develop your own.
Yeah, I think that's absolutely right. So can you give just a brief summary to our listeners of that clinical pathway that's described in the appendix to this paper? So what kinds of patients are deemed candidates for invasive neuromonitoring at your institution and what that kind of pathway looks like practically?
Yeah, absolutely. So we kind of started with a broad definition of, anybody with a diffuse brain injury or the potential for neuroworsening. And that includes a lot of patients. And we specifically outlined that patients with cerebrovascular disease, such as ischemic or hemorrhagic stroke, can be included in this pathway. But we really focus as a site on traumatic brain injury because, again, it's what we tend to see fairly commonly. And then we wanted to know if their clinical exam was such that we might not be able to really follow this patient's brain injury reliably. And so we really stratified things by whether or not you could follow commands or not, and that's a pretty common stratification, I think, in the multimodality monitoring literature. Most people tend to look at a GCS of less than 9 or less than or equal to 8 as their criteria, and we kind of acknowledge that that's a big part of the motor part of the GCS is a big part of that. But we have a fair amount of patients who also have problems with eye opening, who may have an eyelid opening apraxia or have orbital edema from a trauma. And so we kind of said, well, look, if you can follow commands, that's great. And if you can't open your eyes, that patient could have a GCS that's as low as 8. And, it's useful to stratify by following commands specifically because if that eye opening is impaired for other reasons, you might not want to place an intracranial monitor. And we kind of spelled out specific levels of monitoring in general, not just the intracranial stuff, but, are there patients who might be at higher risk that warrant more invasive blood pressure monitoring, EEG monitoring? At our site, we use the pupillometer and occasionally use optic nerve sheath diameters for patients in whom we may not be ready to do invasive intracranial blood pressure monitoring. And so in that supplementary data in that appendix, we actually outline a couple of levels of monitoring, not just invasive monitoring, but maybe kind of a stepped way of approaching a patient who might be in danger but doesn't quite fit criteria. A real key feature that's, our neurosurgery folks brought up and I think really want to make sure that the folks putting in these monitors, the house officers overnight, the people that are putting these monitors really think about is the idea of reassessing patients too on a periodic basis.
Yeah, and I think it was really nice that you in that appendix laid out not just the criteria for who gets an invasive neuromonitor, but kind of the criteria for ICU level monitoring in different tiers of patients based on kind of the severity of their brain injury. One thing I noticed in the appendix was that you also identified patients, I think it was called like a level 3 or tier 3, where these are patients who not only meet criteria for invasive neuromonitoring, but they also have signs of autoregulatory failure or cerebrometabolic crisis. Can you define how you would identify a patient like this?
Yeah, this is not a common concept by any stretch, and I think this was sort of cobbled together to recognize that there's some patients who, their physiology is so vulnerable that, in the clinical experience is probably something a lot of people have had, the patient's brain physiology is so vulnerable that when you wake up the patient or wean sedation rapidly for your wake-up exams, these are the patients who suddenly develop pupillar asymmetry or suddenly have an ICP plateau wave. Something dangerous happens to that patient when you wake them up. So what I did was kind of try to operationalize that to some degree to say, well, if you've got some signs that waking this person up or suddenly increasing their blood pressure by weaning sedation would cause harm, that may be someone to back off on your exams, which is in many ways the point of multimodality monitoring, is to have an early warning sign that doesn't depend on your clinical exam. And so we defined it in a couple of different ways, essentially, kind of recognizing that it may be that there's refractory intracranial pressure, but it may be that something like an autoregulatory index is abnormally elevated, something like the PRX, which is what we use. Other people may use different autoregulatory indices, but if autoregulation appears to be impaired, that may be someone to consider backing off on exam frequencies. And then a variety of other things. So if someone who has an EEG that's been slowing down, their alpha to delta ratios decline, taking this kind of from the subarachnoid hemorrhage literature, or if your site has microdialysis, which we don't report in our paper because we haven't utilized that modality yet, and the lactate pyruvate ratio is elevated. These kind of things tell you that, well, this patient's brain is really vulnerable. It's got the potential for developing secondary brain injury, even in the context of normal nursing or medical care. And so those may be people to back down to something more like a Q4-hour exam or Q12-hour exam even.
I see. So that does make a lot of sense. Another question I just had in terms of the pathway for doing invasive monitoring. Doing invasive neuromonitoring on a regular basis at any center really involves the coordination of a lot of moving parts, even if there is enthusiasm from the perspective of, say, the treating neurointensivist. There needs to be buy-in from collaborating neurosurgeons, a willingness from hospital administration to pay for very expensive supplies and capital equipment, and also sometimes cooperation from other services like epilepsy or EEG that might have a hand in interpreting the data. So can you give us a sense of how some of these issues were practically handled at your center and how that played into developing this pathway?
Yeah, I think the first and most important buy-in is obviously from the folks placing the monitors. So we had neurosurgery was intimately involved in creating this protocol with us, and it was very much a joint effort. And so once I think neurosurgery and neurocritical care were both on board with this idea of, well, we're definitely going to do this, then some of the other practicalities come up, right? Exactly as you said. It's a lot of data, it's a lot of disparate data, and the idea of interpreting it in a clinically meaningful way is not real well defined. There's not a lot of guidance on this, as you pointed out as well. What we ended up doing was trying to invest in some monitoring devices that put a lot of this data in the same place. And that helped us to just have some streamlined connectivity between a lot of these different devices. So that was the first step. And then, we decided we wanted our epilepsy folks to be looking at the EEG while we were simultaneously looking at a different aspect of the EEG in conjunction with the rest of the multimodality monitoring. And so we arranged to patch over the EEG into both systems. And so in this way, we kind of had some backup. We had some different eyes on the data and looking at it in different ways. And then, kind of the third step was, well, how is this integrated from the clinical side of things? How does the neurointensivist, who's rounding it, getting the warning on this patient with severe TBI, how do they actually have a chance to review all of this? And so we essentially developed a service line wherein we have one person who's reviewing all of the data, essentially. And that's done remotely and reported using a standardized template. So that's been really, really useful to be able to sit back, put everything together, and then have that delivered over to the clinical team who can then integrate that into what they recognize is going on with the rest of that person's ICU care.
Yeah, I think, we've had conversations informally about this issue, and it really is, I think, an important thing that gets unnoticed, that interpreting invasive multimodality monitoring data is not something that really can be done by just looking at a screen at the bedside in a snapshot. It really requires the review of trends over time, and in that way it starts to become more like interpreting continuous EEG. And that aspect of using multimodality monitoring data probably should be more emphasized, and hopefully in the future that type of reporting can be standardized across centers.
No, absolutely. I think standardization's ultimately it's the key of advancing this stuff forward. I think there is some low-hanging fruit, though. So for the center, that's just looking at this and saying, well, we'd like to do it, but it seems daunting. There's some low-hanging fruit. The idea of using just simple thresholds is still valuable if you're targeting multiple thresholds. I think that's kind of where we're at in terms of the literature of multimodality monitoring. Using PBTO2 and ICP together to establish thresholds and changing treatment based on which one's abnormal, or maybe both are abnormal, is something that you could do right away. And that doesn't require quite as much, I think, of the nuanced trend interpretation that some of us are doing. So I think even if you don't have maybe someone dedicated at, a specific site who's going to be staring at this data, like an EG service might, there's still some things that I think are value add to having the additional data. And being able to look at it, even at the bedside in trend form, still gives a lot of insights.
You go through a lot of detail, I think, in the heart of the paper describing the safety and reliability of doing intracranial monitoring in the way that you described, which is basically by placing a single burr hole at the bedside and using a multi-lumen bolt that allows the passage of multiple different catheters into brain tissue simultaneously. It was heartening to see that the overall rate of significant complications was quite low. And this is similar to our experience where I practice. One thing that we do occasionally see, however, is that after the invasive catheters are placed, you can sometimes see on a head CT or on a scout film that the catheter takes a sharp abnormal bend or looks kinked. And it's a little bit hard to know whether or not to trust the data from those types of kinked catheters. Is this something that you noticed in any of the patients in your series?
I've definitely seen some odd trajectories. Most of the time they still end up in subcortical white matter, even if the angle is kind of odd or takes off kind of more acutely than it usually does. But I will say when I've seen data from kinked devices that are truly not working, it's usually a non-data that you're getting. So I do feel like it's still trustworthy data.
Yeah, and one thing that I did notice was that although there really weren't many significant hemorrhages in your series, there was only, I think, one patient, there were other non-significant or asymptomatic tract hemorrhages. And those tract hemorrhages may be asymptomatic for the patient, but they could, as you say, affect the quality of the data recording.
Yeah, the small hematomas, they happen frequently. Of course, if centers who use EVDs, you'll see the same thing. And so, the worry becomes, okay, if you've got a hematoma around a catheter or the area of the catheters, usually it's just around one or two of them. Can you rely on the data? Anytime you get a number of measurement, it should respond to other things that are happening. And so one of the first things that I do is approach it scientifically and say, well, if I introduce a change in physiology that should change the brain tissue oxygen, for instance, and the brain tissue oxygen doesn't change, in some ways I have to begin to doubt that brain tissue oxygen. And so on the other hand, if I increase the blood pressure, say, using a touch of Levofed and increase the mean arterial pressure by 10 millimeters of mercury for an hour, and I do see that brain tissue oxygen increase by 5-10 millimeters of mercury, now I'm a little more trusting that that's actually seeing viable blood flow and dissolved oxygen. So that's one way to approach it. I think the other nice thing about having multiple different probes is that you also have concordance of data. And so if I've got a brain tissue oxygen monitor that, just doesn't seem to be reading, it's, got a value that's pretty static and it's not changing with blood pressure, it's not changing with increases in FiO2, I might look at the cerebral blood flow. And, knowing the physiology of these things, the PbTO2 is a function of cerebral blood flow and dissolved AV gradient across the capillary bed. And so you can make an inference that, well, if the cerebral blood flow is where I want it to be, and my PbTO2 is not really responding to these other parameters, then maybe the hematoma that's around this rhometic catheter, maybe it's impeding the dissolved oxygen from hitting that probe. And so that's a pretty common scenario. And in using the different modalities that you've got helps you to also clarify that.
I see. One thing that would be helpful is just from your perspective, what you feel the overall take-home message and the overall kind of results from this paper would be for our listener.
I think that the two big things are, one, a realistic understanding of what you get. I think there are times in which it becomes frustrating that, maybe the PbTO2 doesn't seem to be reading the way you want it to read. But knowing that there's a lag time, knowing that you're not going to get 100% of your data, but you're definitely going to get 90% of the time a usable recording, that's helpful. It's managing expectations in that way. So understanding that the data that you're getting is going to be of a certain quality and you're going to get a certain amount of time of usable data is useful. Nowhere is that more apparent than with cerebral blood flow because that particular catheter requires a lot of calibration. It's got a lot of internal validity checks. And so kind of going into it knowing that you're going to have calibration breaks and that kind of thing is useful. So that's one thing, is just knowing what to expect. And then the second is that it's relatively safe. And I think that's the question that always comes up whenever I'm talking about this with anybody, especially from surgical specialties, is, well, how do we know this is safe? Is this something that we can do, especially in these really torn up brains that come in after, severe trauma? And so the rate of significant hemorrhage is consistently low across doing this, even in patients with other pathologies, is really reassuring that doing this as part of your clinical care is not going to increase the chances of harm, but actually may provide some value-added data.
Yeah, and you also show some interesting examples in your paper where a review of some of these multimodal monitoring trends prompted treatments that appeared to normalize the cerebral physiology that was deranged. Most of these treatments usually involve some type of hemodynamic manipulation that improves tissue perfusion and oxygenation. How often, in your experience, does invasive neuromonitoring prompt a treatment that would otherwise have not been done?
That's a great question. In some respects, I wish we'd quantified it from the beginning. And of course, we didn't have the study design or the power to really quantify efficacy in terms of any particular outcome either. But, I can tell you anecdotally, we make changes all the time based on this stuff. We also debate all the time on this stuff in terms of, well, should we try X, Y, or Z and why? Or do we need to keep trying to modify this particular parameter? Should we back off in terms of the risk-benefit of doing something like increasing blood pressure in this person with an unstable contusion? And so, it leads to a lot of conversations, actually, more than anything else, in terms of what we're doing and why. But what I'll point out is in these examples, the absolute values of, for instance, cerebral perfusion pressure or intracranial pressure are not too abnormal. They may not be values that you would think that changing hemodynamics would make a big impact. And so I think that's the other thing to point out is that one of the big changes is making changes to perfusion pressure that we might not otherwise make just because there is some additional data that's telling us, this patient's having secondary brain injury related to something that you might not otherwise pay attention to or think is quite as severe as it is.
Yeah. And this brings me to another related question, which is you mentioned in the paper that the mortality rate for the patients in your series was higher than what would be predicted by existing models. In the paper, one of the reasons that's stated for why this discrepancy might be there is that it might be due to a selection bias for using intracranial multimodality monitoring in the most severely brain-injured patients. However, another possibility that I just want to put out there is that multimodality monitoring may induce unneeded increases in therapeutic intensity that are in fact detrimental to patients. So a lot of the therapies that we use to alter hemodynamic status, like volume expansion, cerebral perfusion pressure augmentation with pressors, supraphysiologic oxygen, these can cause harm to the body and they can lead to complications such as lung injury and ARDS. So it would be very helpful to get your perspective on the relative balance between therapeutic intensity that you believe is being increased for the benefit of the brain and what the trade-off might be for the body.
Yeah, that's a great point. I think one of the really seminal papers in addressing individual physiology came from Claudia Robertson that really looked at CPP-guided therapy for patients with TBI, demonstrating that by pushing that pressure up, you actually increase the incidence of ARDS. And that really, I think, gives pause to going nuts over trying to tweak every number perfectly. The other end of the argument uses some data from the folks at Cambridge who look at autoregulation and suggest that the higher you go past your optimum CPP, the more you create morbidity, but not necessarily mortality. And so there's also kind of this effect where we're, in some cases, maybe even keeping people alive longer to perhaps a worse outcome. And so both of these things need to be explored in some form of a randomized controlled way. And then, one of the things that's poorly quantified across ICU literature in general is withdrawal of care decision making, which does impact a lot of these patients. So our survival being less than would have been predicted is in part too because of family decisions for goals of care. So there's a whole lot of reasons, and I think all of these have to be taken into account in kind of the next generation of ICU trials. Anecdotally, I'll tell you, I think there are some patients who develop lung pathology as a result of, really aggressive FiO2 settings, but we haven't included that in our treatment algorithm.
A final kind of speculative question. Do you think that invasive multimodality monitoring should be more widely adopted, or do we need to wait to establish that these monitoring strategies actually improve outcomes?
Yeah, it's a great question. It depends. If you are, I think, in a shop where you deal with high volumes, just kind of like you mentioned at the beginning of the podcast, you're in a shop that has high volumes, you are managing folks with EVDs, there's limited resources to do this, it may not be quite time to dive in fully. And so I think for sites that are interested and have a person or a group of people who are interested and willing to kind of tackle this, I think it's reasonable, and there's enough data out there that says preliminarily this could help, but you got to be pretty mindful of how you're using it. And so we're on the cusp, and I think we're going to see over the next couple of years some data that comes out that I think pushes us one direction or another in more of a definitive way.
All right. Thanks so much, Brendan, for taking time to speak with me. It was really great to be able to talk to you about the work that you're doing and the paper that you guys just published in Neurocritical Care.
Thank you for having me on, Ram. I appreciate it.
Thanks for listening to the Neurocritical Care Society podcast. The NCS podcast is produced by the Neurocritical Care Society, whose mission is to promote quality patient care, professional collaboration, research, training, and education in neurocritical care. Our production staff includes Josh Levine, Mike Brogan, Romani Ballou, Storane Shepard, and Benjamin Miller. Our senior producer is Jim Siegler. Our administrative staff includes Sarah Memon and Becca Stickney. Music by Lee Roussever under Creative Commons license. If you like our show and want to know more about us, check us out on Twitter at Neurocritical, Facebook, or LinkedIn. The NCS podcast is available at NCS On Demand, iTunes, and wherever you may listen to your podcasts. I'm Fawaz Al-Mufti, and thanks for listening.